Okay, chapter 27, face and neck injuries, EMT class. So, introduction, face and neck are very vulnerable to injury. And we know that, with those injuries, we can see a lot of different things and lots of trauma, lots of blood. Where the head goes, the body follows. So the head many times is going to take some pretty good shots here. But they're protected, or they're particularly vulnerable to injury because they're relatively unprotected positions on the body. So soft tissue injuries and fractures are very common, and they do vary in severity as well. As you can imagine, some of these injuries are going to be life-threatening. So, penetrating trauma to the neck obviously can cause a lot of severe bleeding. Even an open injury can allow an air embolism, which we've talked about, to enter the circulatory system. So one other thought, is if a hematoma forms in this area, depending upon maybe airway or, within the brain or something, a hematoma can form and it can stop or slow blood flow to the brain, causing a stroke. So there's a lot of different things that we can see and experience with these kind of trauma patients. The upside is, with appropriate pre-hospital and hospital care, a patient with seemingly devastating injuries, it can have a surprisingly good outcome. The technology and the way that medical care has changed, over the number of years, we're able to take some really bad situations and make a pretty good situation out of it. So let's talk about the head. Head's divided into a couple of things. So we've got the cranium, so it's also referred to as a skull. What it does, obviously, it contains the brain. So now the brain, it connects to the spinal cord through the foramen magnum, and which is a large opening at the base of the skull. Now the most posterior portion of the cranium, that's going to be called the occiput. On each side of the cranium, the lateral portions are called the temples, or the temporal regions. And then between the temporal regions and the occiput lie the parietal regions. Now the forehead, that's going to be in the frontal region. So anterior to the ear, in the temporal region, you can feel the pulse of the superficial temporal artery. So obviously we're just talking about a lot of little anatomical pieces here and just kind of some landmarks and kind of a map, so just be able to recognize some of this stuff. Now within the face, you've got the eyes, the ears, the nose, the mouth, the cheeks, lots of components. 6 major bones include the nasal bone, 2 zygomas, 2 maxillas, and a mandible. You see here what we're talking about. So we've got the maxilla, we've got the mandible, zygoma, nasal bone. Now the orbit of the eye is composed of a couple of different pieces. The lower edge of the frontal bone of the skull, the zygoma, the maxilla, the nasal bone, we just looked at all of that. The bony orbit protects the eye from injury, so it is able to provide a little bit of protection in that area. Now only the proximal third of the nose is formed by bone. The rest of it is going to be formed by cartilage. It's all composed of cartilage. Now the exposed portion of the ear is composed entirely of cartilage covered by skin. So the external, the visible part, that's called the pinna. The tragus is a small, rounded, fleshy bulge immediately anterior to the ear canal, and then the superficial temporal artery can be palpated just anterior to the tragus. Excuse me. Still talking about the face here. About 1 inch posterior to the external opening of the ear, that's going to be the mastoid process. Talking about the bony mass at the base of the skull. Now the mandible, that forms the jaw and the bone. The jaw is the lower third, the lower border of the mouth, where the tongue and 32 teeth are located. Motion of the mandible occurs at the temporomandibular joint, which lies just in front of the ear on either side of the face. Now below the ear and anterior to the mastoid process, the angle of the mandible is very easily palpated, and that's important for several procedures that we do and the way that we size things up, and it's important to know these landmarks and what is what. Moving down to the neck. So it contains obviously some very important structures. It is supported by the cervical spine, which first 7 vertebrae in the spinal column are the cervical C1 through C7. The spinal cord exits through the foramen magnum and lies within the spinal canal, formed by the vertebrae. So the upper part of the esophagus and the trachea, they lie midline in the neck. And then those carotid arteries, those are found on either side of the trachea, along with the jugular veins and several nerves. And here we kind of see some things in the throat of what we're talking about. So the larynx, the Adam's apple, is located in the center of the anterior of the neck. It's the upper part of the larynx. When we talk about the Adam's apple, it's the upper part of the larynx. It's formed by the thyroid cartilage. Now, it's more prominent in men than in women. And the other portion of the larynx is the cricoid cartilage, which is a firm ridge of cartilage below the thyroid cartilage. So here we see is the thyroid cartilage. Whoops, I'm sorry, I'm on my picture. Here we see is the thyroid cartilage, and then we've got the cricoid cartilage. And then right here we have the cricothyroid membrane. That's that tissue between. So you have the cricothyroid membrane. It lies between the thyroid cartilage and the cricoid cartilage. And then that soft depression in the midline of the neck is what we're talking about. So here's this area that we're talking about. Now, within the trachea, below the larynx, the trachea is below the larynx. It connects the oropharynx and the larynx with the main passages of the lungs. That's why it's going to be important. The bronchi is what we're talking about. So on either side of the lower larynx, the upper trachea lies the thyroid gland. So then you get in there and you get down to the sternocleidomastoid muscles. They originate from the mastoid process of the cranium and insert into the medial border of each collarbone and sternum at the base of the neck. What they do is they allow movement of the head. I know, just a lot of just straight up facts. So just pay attention to your facts. Get to know these things, you know, the important things. Many of this stuff is pretty important. It's not all that fun. And then the eye. So the it's globe-shaped, approximately about 1 inch in diameter, located within a bony socket in the skull called the orbit. Now the orbit's composed of the adjacent bones of the face and the skull. In adults, the orbit protects about 80% of the eyeball. And that's between and below the orbits are the nasal bone and the sinuses. So here we have the eyeball, lots of different pieces here. Cornea, pupil, the lens, I'll go all the way back here to the optic nerves. These are going to be very important, obviously. Any type, something within the nervous system is obviously going to be important. The eye, clear jelly-like fluid near the back of the eye, that's going to be called the vitreous humor. Then in front of the lens is a clear fluid called the aqueous humor. So in penetrating injuries of the eye, the aqueous humor can leak out. But with time and appropriate medical treatment, the body can make some more and get back to normal. So the conjunctiva is a membrane that covers the eye. Lacrimal glands, often called tear glands, they produce fluid to keep the eyes moist. So when you blink, then fluid is swept from the lacrimal glands over the surface of the eye. And what that does is it's cleaning it. So it's continually cleaning it, getting the dust off and whatever else might be in there. And so we get on down to tears drain on the inner side of the eye through 2 lacrimal ducts into the nasal cavity. Now, the sclera, it's going to be the white fibrous tissue that helps maintain the globular shape and protects the more delicate inner structures. In the front of the eye, the sclera is replaced by a clear transparent membrane called the cornea. So what that cornea does, it allows light to enter into the eye. The iris is a circular muscle behind the cornea. The iris acts like a camera to adjust the size of the opening to regulate the amount of light that enters the eye. So when we talk about fight or flight and all of that, these things, it works all the way down to this degree of body changing for that fight or flight system, because you start getting things to dilate or constrict depending upon what's going on. So that's what we're talking about, the size of the opening. So the iris is pigmented, and that's what gives the eye its color. Now the pupil is the opening in the center of the iris. So, allows light to move to the back of the eye. The anisocoria is a condition in which the person is born with different size pupils, which could throw you off if it's a considerable difference and you're afraid somebody had a head injury and you saw different size pupils. That's why it would be a good time, if things aren't adding up, that you ask the patient. Have you ever been told you have different size pupils or anisocoria? that would give you an idea of what you could expect. If like things are off, but it doesn't seem like they should be, then you can certainly ask that question. So now in unconscious patients, though, these unequal pupils, they can indicate a serious illness or a serious injury. So that's why if we have the ability to ask them, we want to make sure that we do if they have different sized pupils, unequal pupils. Now that lens behind the iris, lies behind the iris. The lens focuses the images on the retina at the back of the globe. The retina contains nerve endings. So they respond to light by transmitting nerve impulses through the optic nerve to the brain. And the retina is nourished by a layer of blood vessels between it and the back of the globe, called the choroid. Now, retinal detachments, when the retina detaches from the underlying choroid and sclera, and the really bad part about that is it causes blindness and can be a pretty severe, debilitating injury. Injuries of the face and the neck. So injuries about the face and the neck can often lead to partial or complete obstruction of the airway. We want to, that's something we need to be very aware of and be thinking about when we see these kind of injuries, because we could certainly have some type of airway obstruction. It might be slight or it might be complete and severe. So several factors can contribute to this, but blood clots in the upper airway from heavy facial bleeding, that can sure be a contributing factor here for airway obstruction. They can lead to complete obstruction, but when we're talking about like an unconscious patient, then there can be some real problems because they're unable to maintain their own airway. Now, direct injuries to the nose and the mouth, the larynx, the trachea are often a source of significant bleeding and or respiratory compromise. So you may need to suction the airway for these kind of patients. And you have something to be thinking about too is, these kind of injuries can cause some teeth problems. The teeth can become dislodged in the throat. And then if you have a patient with some dentures, that could be a real problem because now you've got the whole set of dentures crammed in there. Swelling that accompanies direct and indirect injury to the soft tissues can also contribute to airway obstruction. So talking about the airway, it can also be affected when the patient's head is turned to the side. We could start shutting it down. So, this is often the case with altered LOCs, level of consciousness, or even an unconscious patient. Now, possible injuries to the brain and or cervical spine may interfere with normal respirations. We know that respiratory patterns can be changed. You can, the depth and the quality of respiration or ventilation can be changed. So you see a lot of things with head injuries. If the great vessels in the neck are injured, then significant bleeding and pressure on the upper airway are quite common. Now, we covered soft tissue injuries. We know they're very common. Face and neck are extremely vascular. Swelling in this area can be severe. Mima fell down and hit her head and probably got a big hematoma in there, and they either removed it or the body kind of removed it. It just started breaking it down. But this is a very common thing, and bleeding from these type of injuries obviously can be very heavy. Even minor soft tissue wounds of the face and neck can bleed quite well. We've mentioned it that how vascular this area is, but we've got to be prepared for that. So a blunt injury can cause a hematoma, and even sometimes maybe an avulsion, so that flap of skin, that's kind of peeled back or it's moved. Now, dental injuries. Mandible injuries are common because of its prominence, second only to nasal fractures in frequency. Most of these fractures are the result of vehicle collisions and assaults. But some signs and symptoms, signs of mandible fractures include misalignment of the teeth, numbness of the chin, inability to open the mouth. Those are all things that should make us think there could be a mandible fracture. Maxillary fractures are usually found after blunt force and high energy impacts. So when we start thinking about this, what we might see is some massive facial swelling or instability of facial bones. Once again, misalignment of teeth. But fractured teeth are common following facial trauma. It's not something that's uncommon with this. So teeth fragments can become a real problem, talking about airway obstruction, and these things need to be removed immediately. All right, let's move on. So scene safety, not a lot of change. I know I say this every time, but if we're doing scene safety correct, there shouldn't be many changes. So eye protection and face mask, probably going to be a good idea if we're talking about, face and neck trauma. Someone can have a possibility of spitting some stuff on us, whether it's intentional or not. When I assess the scene, look for different things that we see and what could have caused the problems and what kind of problems can we expect. As always, we want to focus on identifying and managing life-threatening concerns. So, ABCs need to be treated immediately, as always. We know that if there is life-threatening external hemorrhage, that jumps in front of the A and the B. So we immediately, when trauma, we immediately go to C, and then we can move airway and breathing. That's, in medical calls, we don't do that, but here we do. Well, medical calls just saying we shouldn't see a lot of external bleeding, right? So want to get that general impression. Look for important indicators of the seriousness of the patient's condition. And we've talked about what those are many times. So when you got someone that looks shocky or someone that just looks sick, their color is bad, their altered respiratory patterns, those kind of things, that should give us an idea. One of the things we want to do is consider the need for manual stabilization. So we may need to manually get a hold of their C-spine and hold it until we're able to get a collar on them if we do believe that there could be some C-spine injuries. And then obviously, we're going to check for responsiveness. And we move down to our A, B's, and C's. So ensure a clear and patent airway. Now, if they're unresponsive or even have a significantly altered LOC, we may want to consider looking at an OPA or even an NPA. Now, the problem with this is the NPA can be controversial because of the possibility of insertion directly into the cranial vault, which sounds weird, but it is contraindicated when we start talking about some head injury stuff. So if that does happen, then that NPA is going to go into the brain tissue. So we want to make sure that we're aware of this and follow our local protocols for however that is determined. Want to quickly assess for adequacy of breathing. We get back that decap BTLS, so we're going to look for the chest wall for decap BTLS. If penetrating trauma, if we see some penetrating trauma, we want to place occlusive dressing on that wound right away. You want to maintain the airway, so we're talking about supplemental O2, may need to ventilate them if necessary, those type of things. Check for breath sounds, and then we know we want to get moving, so provide rapid transport to the hospital. If these kind of things are abnormal, then we want to start thinking we need to be moving and getting to the hospital. Splinting or otherwise restricting chest wall motion is contraindicated. So splinting is ineffective and can impair air exchange. So we don't want to wrap up someone's chest. Maybe we think they have rib issues or flail segments and all that kind of stuff. We don't want to deal with that in that manner because it will restrict air exchange. Then we get down to our C. So we're on circulation, must quickly assess the pulse rate and the quality, want to look at the skin condition and color and temp, capillary refill, and we know that significant bleeding is an immediate life threat, so we want to have already dealt with that. Transport decisions, sick or not sick, right? So consider quickly transporting patients with airway, breathing, circulation, any of those things where they have some problems with that, we may want to consider getting them out of there and going. So load and go is what we're talking about. Stabilization and maintenance of an airway and breathing, as well as control of bleeding, can be very difficult with these patients with these facial and neck injuries. So, if you're going to have a long time here, you may want to think about ALS backup. You may want to think about a rendezvous with somebody. Now, if you have a patient that you think there's going to be some internal bleeding, then once again, we just like with external bleeding, we need to get moving. We need to think that this is a load and go situation, and we need to get moving. One of the things that you may not think about, hopefully you do, but this internal bleeding, that can certainly compromise blood flow to the brain, and we know that that's not a good thing. So we want to be making the right decision here, as well as that's something that we're unable to see, but something that we can see. So bleeding from major vessels of the throat obviously can also impact the patient's airway. So that's going to be a real big problem as well. Now we're talking about when you look at this, hopefully you look and go, yeah, we're talking about shock here, hypoperfusion, right? These are things that we've talked about multiple times, many, many times. And that ought to tell you how important it is. If you see one thing throughout this program 18 different times, and about 12 of them are said exactly the same way, that should tell you this is very important. So for us to be able to recognize shock is going to be extremely important. Tachycardia, tachypnea, low blood pressure, weak pulse, all of these things, because these people die in the back of ambulances quite frequently. We need to make sure that we recognize this and get moving, because while we're waiting around on scene and doing other things that are not all that important, that's how these people end up dying. We've only got so much time with them, and the longer we spread it out, the greater chance we have to negatively impact them. So we're still talking about transport decisions. So if they have a significant MOI, their condition appears stable, they still should probably be transported promptly. We're unable to see what's going on within the body, but if there is a lot of energy or a death in the same vehicle and all these kinds of things, we probably need to take that pretty serious and get moving. One thing to think about is if we start talking about, when we're talking about significant energy, that if they have a significant blow to the face or the throat as well, we should increase our suspicion for spinal or brain injuries as well. So even if these patients, when we look at them and they have no signs of hypoperfusion or shock, or even other life-threatening injuries, there is possibility of eye injuries too. So, these things are considered serious. They should be transported to the hospital as quickly and obviously safely as possible. Surgery and or restoration of circulation to the eye will need to be accomplished within 30 minutes or permanent blindness can result. So once again, just more and more reasons to not mess around with these patients. History taking, get all that we can, be aware of pertinent negatives. We've talked about pertinent negatives and what exactly we're talking about. So, kind of those things you may or may not expect to find, and we're documenting, that what the issue is. So they got hit in the head, but they denied a loss of consciousness. That's the kind of stuff that we're talking about with those pertinent negatives. You want to get a sample history from your patient, family, friends, whoever you can, if you are able to. Secondary assessment. So if multiple systems have been affected, start with an assessment of the entire body. If you have the time, if we're able to move on from our primary of our A, B's, and C's, then we want to start looking at everything. So, but keeping in mind, you may not always have time to conduct that secondary assessment. But if we do want to try to perform a detailed examination of some specific areas, we don't want to delay transport with this. In a responsive patient who has an isolated injury with a limited mechanism of injury, then we can consider focusing our physical examination on the isolated injury and their complaint, and then the body's region that was affected as well. Want to make sure that we're getting all this bleeding taken care of. We're always looking to re-examining, we're reassessing what we did and making sure that things are still working. Want to make sure that if we've talked about it already, but if you do have an impaled object, that we stabilized it and that it's continuing to be stabilized. So during our physical exam, we're needing to use both our eyes and our hands, right? We're going to be looking for things and we're going to be feeling for things. So we're looking for swelling, deformities, contusions, all these kind of things, discoloration, some bruising patterns, all of that. But we're also palpating things, looking at their face and looking and feeling for any abnormalities. So if your patient is responsive, you should explain exactly what we're doing and what we're looking for. So, we might even, discovery of an abnormality, it may be an old injury, or it might be the fact that they just have unequal pupils and all of that. So that's why we need to be talking and communicating with these people. We want to make sure that we're assessing all of the underlying systems. So, we want to look at the neurologic system, including the brain and the major nerves, the eyes and the nose, make sure that we're taking care of the respiratory system. So all of these go along with just the exam that we're going to do and the questions that we're going to ask. When evaluating the eyes, we want to start with the outer aspect and work towards the pupils. So we want to examine the eye for any foreign matter, obviously. Visual acuity is considered the vital sign of the eye. So if you were going to check their visual acuity, you want to gently cover one eye and hold fingers up at arm's length in front of the open eye. And then you test both eyes for the ability to see fingers. So, some of the things we're looking for, you want to note any discoloration of the eye, bleeding in the iris area, redness, eye symmetry. You want to look at each pupil for equal size, for reaction to light, that whole pearl thing that we've talked about. If pupils are not symmetric, we want to inquire about previous surgeries, or maybe they have injuries or they have congenital issues. So you want to make sure that if they do have unequal pupils, that have they been caused by a physiological or a pathological reason, something that's gone on in their life, or is it from a injury? And then vital signs. We want to get some good vital signs. So we want to be concerned with getting a full set of vital signs, especially if we have airway issues and all of that. That's going to be really important that we get that. Reassessment. Not a lot of changes here. Once again, repeat the primary assessment, reassess vitals and the chief complaint. So we're always going back to our A, B's, and C's, right? It's going to be important with these guys with facial or neck injuries because these injuries can affect the body very quickly. So if these are critical patients, every 5 minutes, stable patients, every 15, but we're talking about people with airway issues and neck and throat issues, we probably want to assess them every 5 minutes because they have the possibility of having some real problems. Maintain that open airway. With these, you need to be prepared to suction the patient. And you may need to consider an OPA. If you have somebody that's unresponsive, you probably are going to need to put an OPA in and then make sure we're doing lots and lots of good suctioning. Whenever you suspect significant bleeding, we want to provide some high flow O2, right? If we think of shock or hypoperfusion, we want to provide O2, keep warm, recognize that, get moving, all of that. May need to assist ventilations. If we do, we want to use high flow O2. And then obviously through our reassessment, we want to control any significant visible bleeding. Just talked about this. If they have signs of hypoperfusion or shock, we want to treat them aggressively and provide rapid transport. So don't delay the transport of a seriously injured patient to complete non-life-saving treatments in the field. Don't worry about splinting legs when, if you've got a patient in shock. We need to get them to the hospital so we can get them into the ER and a surgery suite so they can get things fixed. Now, in communication and documentation, we want to do a good description of what went on, a good description of the mechanism of injury and the position in which you found the patient. Remember, we've mentioned this, but we want to paint a clear and vivid picture for whoever is reading that report. So we want them to understand what's going on and what we saw. Now, if the case is a motor vehicle crashes, we want to go ahead and document the method used to remove the patient from the vehicle. So maybe you had to do a rapid extrication, or maybe you put them in a KED or whatever. You want to document that. And you always want to document when you provided C-spine protection, immobilization, that you did that. So we extricated the patient out of the front seat, providing C-spine protection, loaded them onto a long spine board with 3 straps, 4 straps, whatever it is, however you guys do things. But you want to document that you gave C-spine protection on these patients. Now, in patients with severe external bleeding, it is important for us to recognize this, right? Recognize, estimate, report the amount of blood loss that has occurred. As I've mentioned, that's not a very easy thing because it's just weird. It's hard to figure out blood when it's laying out on the ground of how much it is. But you can certainly estimate. So you want to inform the hospital about all the injuries involving the head and neck. And they may need to get some specialists involved, for teeth or sinuses and mouth and all this stuff. All right, hang on. Okay, moving on to emergency medical care. So want to treat these soft tissue injuries the same as soft tissue injuries elsewhere on the body. So when we're dealing with the neck and the face, we want to treat them as soft tissue injuries other places. Obviously, we're assessing the A, B's, and C's and fixing life threats. First, we're following standard precautions, of course. In the absence of life-threatening bleeding, we're talking about replacing C into the front, placing it in the front. In the absence of needing to do that, first step is to open and clear the airway. The patient may need frequent suctioning. If there's a lot of blood, you may need to suction them quite frequently As we've mentioned, remember you're also removing oxygen though, so pay attention to that. They may need to be ventilated frequently if they're not moving air well because you're sucking out oxygen for them. So, just something to think about. Avoid moving the neck in these patients. If you have a suspected cervical spine injury, we don't want to do that. We want to use that good jaw thrust maneuver to open the airway and suction the mouth. Now, once they're immobilized, you can turn the backboard to one side to allow blood or some vomit to drain from their mouth. But they need to be immobilized well before you start rolling a backboard over to the side so they can do that. Control bleeding by applying direct manual pressure with a dry, sterile dressing. So use roller gauze, wrapped around the circumference of the head. That'll help provide some pressure dressing, for a head bleed type thing or something. You don't want to apply excessive pressure, though, if there is the possibility of an underlying skull fracture. And, we don't need to wrap this thing super tight. We just need to put a little bit of pressure on it and cover it up. So when an injury exposes, maybe the brain or the eye or other structures, we want to cover those exposed parts with a moist or sterile dressing. So apply ice locally to injuries that do not break the skin if that's in your protocols. For soft tissue injuries around the mouth, check for bleeding inside the mouth. So broken teeth and lacerations to the tongue may cause profuse bleeding and obstruction of the upper airway. Often a patient will swallow blood, so that's kind of yucky. So the hemorrhage, first off, may not be apparent, as well as if these patients do swallow this blood, they're going to be more prone to vomiting for the body to get rid of that stuff. So we can get around doing that. Let's do that. So, thinking about physicians can graft a piece of avulsed skin back into its appropriate position. So we want to be able to try to take care of that portion of skin. So wrap that in a sterile dressing. If this is stuff that's just like been actually removed, it's not still attached. Our curriculum talks about wrapping that in a sterile dressing, place it in a plastic bag, and keep it cool, because that's something that the physician can fix. You don't want to put it on ice. Freezing will destroy the tissues. But as we said, if possible, sterile dressing, plastic bag, and keep cool. And then you want to make sure you deliver that to the ER. More times than not, this is more what you're going to deal with. So the skin is still attached in a loose flap. Place the flap in a position that holds as close to normal as possible. You want to hold it in place with a dry, sterile dressing. So that's more than likely what you're probably going to be dealing with. Now, injuries of the eye. So eye injuries are going to be very common, particularly in sports. They can produce lifelong complications, as you can imagine, including blindness. So good treatment is going to be really important, that we do proper emergency treatment, because for one thing, it'll help minimize pain, and then it could also prevent some permanent loss of vision. In a normal, uninjured eye, the entire circle of the iris is visible. So the pupils are round, usually equal in size, and then they react also. They react equally when exposed to light. Both eyes also move together in the same direction when following the finger. So after an injury, pupil reaction or shape and eye movement, many of those things are often disturbed. So thinking about what we may or may not see, knowing that abnormal pupil reactions sometimes are a sign of brain injury rather than an eye injury. So you want to start with a thorough exam. You always want to use standard precautions, of course. Look for specific abnormalities or conditions that may suggest the nature of the injury. So like damaged cornea, it quickly loses its smooth, wet appearance in someone's eye. Foreign objects. So the orbit protects the eye from the penetration of large objects. Even a very small object, though, can produce some severe irritation. If you've ever taken care of someone that was like grinding metal, a little bitty piece of metal in there, and it is a big time deal because it's really bothering people. It hurts a lot and causes quite a bit of damage too. So the conjunctiva becomes inflamed and red, a condition known as conjunctivitis, and the eye begins to produce tears in an attempt to flush out the object. So irritation of the cornea or conjunctiva causes intense pain. We're just talking about that. So we want to irrigate with sterile saline, a lot of it. Frequently that'll flush that stuff away, these small particles. Injuries of the eye, foreign object. Injuries of the eye, foreign object.